Hello, welcome everyone. Just give a minute for all the systems to connect and all the audios and cameras and everything we need. Thank you. So I'm Adelina Comas-Herrera. I'm delighted to welcome you to today's webinar from the Global Observatory of Long-Term Care. I'll give a very brief introduction just so you also know, in fact, what's coming next. I think many of you are already familiar with the Observatory, but as it's a knowledge exchange platform that is trying to support cross-national learning to improve and strengthen care systems, part of the International Long-Term Care Policy Network, and is basically powered by your willingness to share your knowledge through publications, webinars, blogs, and all sorts of ways in which people are already contributing. And we've gradually built up a database of experts listed by country, topics, and methods, publications, research projects, and videos of webinars. And really, the motor of the observatory are the interest groups like this one. It's one of our favorite ones because it's so active and there's always such great discussions. And so I'm just very happy to welcome you to today's webinar on complexity of orofacial pain in nursing homes with Frank Lozu. I don't know how to pronounce it, but I think Sandra will know when she does her introduction. And I'll just quickly let you know about our next webinars. We've got one on the 29th of June on a very different topic on perinatal mental health, on using economic evidence to make the case for policy change. We've got another one in Spanish. You're interested in long-term care in Spain and speak Spanish on the new reforms of the laws of disability and dependency. On the 7th of July, one from the quasi-experimental methods interest group comparing the effects of private versus shared rooms on nursing home resident health outcomes in the US. And then on the 13th of July, we're going to have one on embedding design principles for cross-boundary collaboration in long-term care, looking at opportunities and challenges, looking at some examples of work on this. So I'm very happy to welcome you all and give the word to Sandra, who's going to introduce the Pain in Care Homes Interest Group. All yours, Sandra.
Yes, thanks a lot. Also on behalf of me and also on behalf of Manuela, a warm welcome, especially to this interest group. I think we started it a couple of years ago, the initiative, and meanwhile, we highly depend on all of you, of course, for your engagement and the willingness indeed to share your knowledge. Also for the upcoming year, we have scheduled some very interesting webinars. But I also would like to use this opportunity to invite all of you, if you are really interested in sharing your knowledge either, or coming up with a topic and thinking, hey, I would like to know more about this. I'm not sure who can add to that, but please let us know, because we're really willing to do this together and to schedule these meetings to all of our interests. For today, we invited Frank Lobezo, stationed in Amsterdam as well, I think, for work at the ACTA. Frank, some of us may know you, some of us not, so I think you will introduce yourself, but we are very pleased that you could join us today and are willing and that you are willing to share your knowledge with us. So I hand over to you, if that's all right. And
of course.
Once again, many thanks for joining us.
Well, thank you very much, Sandra. I will start, of course, with trying to share my screen, which must be possible. Let's see. So what I was saying is, thank you very much, Sandra, for introducing me and for inviting me. I was not aware of this network, I must admit, but having read about the network and also having heard the introduction before and seeing all the activities that you organize in such a short time span with all the interesting topics, I'm highly impressed. So maybe if it's possible, I might join every now and then as well, because it's It's really interesting topics that you're covering. So also for that reason, thank you so much. I'm a dentist. I'm a professor in orofacial pain with a special interest in special patient populations, especially in people with who are a bit older and sometimes have dementia, mild cognitive impairment, Parkinson's disease, etc. So I was trained as an orofacial pain specialist working with otherwise healthy individuals, but my research interest is shifting over the years more and more towards the special needs populations. And I'm pleased that you allow me to tell a little bit about orofacial pain in nursing home residents, for which I will give you a little bit of information, but also use a long stretch towards arriving at the nursing homes, because I think that it is important that we all know what lies ahead of finally arriving in the nursing home. So what is orofacial pain? How do we define it, etc. But first, my employer, the University of Amsterdam. ACTA is the dental school. We have 3 dental schools in the Netherlands, and the biggest is in Amsterdam by far, and it's also one of the biggest in Europe. In the past, I could say it was one of the biggest in the world, but nowadays, with emerging markets in Asia especially, there are huge dental schools that we cannot even stand in the shade. But for European standards, we are still one of the biggest. And we rank high in the QS ranking, number 3, number 2, number 3, number 2. We've never been number 1. But the number 1 is always changing. So somehow I'm more proud of the stable top 3 position. So this is how the school looks like. It's from 2010, but it still looks like brand new. The interior is nice. It looks a bit like a convenience store, I think, with all the escalators. But it's when I walk to the building every morning early from the train station, I still think, yes, it's a pleasure and an honor to work in an environment like that, in a building like that. So this is my department. My department focuses on 3 different topics. We focus, of course, on orofacial pain, which is the topic of today, but also on movement disorders of the jaw. Everybody knows the grinding and the clenching of the teeth, which is the most commonly known movement disorder, but also more neurological disorders like dyskinesias, dystonias, focal manifestations of generalized movement disorders, which you every now and then see in Parkinson's disease. I'll tell a little bit more about that later. And also dental sleep disorders are part of this. And you might wonder, what are dental sleep disorders? What has dentistry to do with sleep? Well, quite a bit. It's not only the grinding that people can do during their sleep, it is also the sleep apnea problems, in which the dentist plays sometimes an even crucial role in the management of sleep apnea by creating devices that can pull the lower jaw forward, thereby keeping the upper airway open. But also reflux problems have their influence on the dentition. Reflux is acid. If it goes into the mouth, you can have malignancies, you can have wear of the teeth. So there's all kinds of interactions with sleep and dentistry. That's also part of my department. So it's a very broad thing that we are doing. But for today, again, I will focus mainly on the orofacial pain and a little bit on the movement disorders. Oh, this is my team. I have a big team. It's a big department. It's 25 tenured staff members with 3 full professors, a couple of associate professors, and quite a bit of assistant professors. I have a few guests who come every now and then, my support personnel, and we have a specialty training for dentists who want to specialize in orofacial pain, which is open at least for EU dentists. So if you know a dentist in your own surroundings who might be interested in this, we'll just point them out to this program, and we are more than open to international students there. There must be dentists though. And we have currently 26 active PhD students attached to the department, which is a lot, but I have a great team. You saw a great in number, but also in quality as far as I'm concerned. So we can supervise them. And we do about 4 to 6 PhD defenses per year. So it's a nice active team. And part of this team is focusing on elderly care and nursing home. So first, you all know the International Association for the Study of Pain, the IASP, and in 2013 they declared the year of orofacial pain, which means that there is special attention to what is orofacial pain, what should we all know about it, how should we manage it, and they also defined orofacial pain in a very simple way. They say that orofacial pain is pain that is associated with the hard and soft tissues of the face and the oral cavity. So that's basically what it is. Everything in and around the mouth and also in the face, that is orofacial pain, and that is what I am dealing with. My department does not deal with toothache. I can handle some questions on this. If you might have questions, I know, since I'm also a dentist, I know about toothache, but that's not my department. My department does all the pains except for toothache. That's another department. And I do not want to have fights with them to claim that is also mine. And I'm happy to it. It's a prevalent condition. In the general population, there's many studies, but one of the best studies done, they claim that almost a quarter of the general population reports orofacial pain in the past 6 months. And that is a lot. So if it's out there in the general population, in people who can say that they have pain, imagine how big the problem can be in nursing homes where not everybody can still say that they are in pain. And you will see later on that indeed the percentages can be quite a bit higher. So being on the threshold of medicine and dentistry, we work a lot together with medical doctors and with medical specialists. It's really an interdisciplinary condition that we are dealing with. We work with neurologists, ENT specialists, anesthesiologists, clinical neurophysiologists, you name it. We have connections with them, and we need it because otherwise we cannot manage our increasingly complicated patients. It's complex material that we work. It's multi-morbid, multi-etiological factors. It's a lot of things, and that's interesting because it's like a puzzle. I like making puzzles. It's a diagnostic puzzle, and also personalized medicine. All the patients require a specific approach, and yeah, that's something that I like to do, like to manage. This is a little movie. Watch closely. It's subtitled. Can you hear the sound?
We don't hear the sound.
No sound? Okay. Okay, so then this little movie. Sorry for the sound. I'm never good in testing sound of these kinds of movies. It's an old lady who receives care at home. She's still living at home, and the lady taking care of her, she discovers a very dried toothbrush on the sink, very dry, hardly used. So she is worried when she sees that, and she asks the old lady, "How do you ever go to the dentist?" And then the lady says, "No, why should I go to the dentist? My teeth are really strong. I only go when I have pain." So this illustrates, this little movie, that in people who are losing their cognitive abilities, that pain is something that they connect with dentistry. They are not thinking about prevention. They are not thinking about being able to chew or to smile. No, it's about pain. And when you have pain, you go to the dentist. In the end of my presentation, I will show another video. There's no spoken language there. It's just a nice music. You will not hear the music, but it's nice music. You will see that she is admitted to a nursing home, and that care is being given to her by a dentist specializing in taking care of people with dental problems in nursing homes. But that's at the end. So this is the preface. And in the end, you will see what happens to her when she is finally admitted to a place where good care can be taken, also for her mouth. So what are the aims of my presentation? First of all, I'd like to provide an overview of the research that we do at ACTA. That makes me most comfortable to discuss that on orofacial pain in older adults, and then especially zooming in on the nursing home residents. I will give then special attention to Parkinson's disease, to mild cognitive impairment, and also to dementia. It's all kinds of conditions that you're for sure very familiar with, but nevertheless, I would like to highlight the importance of palliative oral care. So what happens when the end of life is reached? Also, oral care is still important there, mostly forgotten. And I would like to elaborate on the urgent need for strong interprofessional collaboration. I already mentioned that my discipline is interprofessional as it is, but also in nursing homes, it's not only the dentist who can do the job. Also, dentists working there have to work together with all the medical people who are involved in the care of those patients. So Parkinson's disease, and please interrupt me if I am going to give you details that you're so familiar with that it's going to be boring. But you know that Parkinson's disease has been named after a UK doctor, James Parkinson, long time ago. And this is associated with the loss of nigral dopaminergic neurons, and also the Lewy bodies are widespread increasingly in people suffering from Parkinson's disease. These symptoms are known: the slowness of movement, the bradykinesia and the tremor. If you think about Parkinson, you think about that. But the non-motor symptoms are less known. The cognitive decline, you might be familiar with it, but also that these people suffer increasingly from pain, widespread, but also orofacial is less known, at least in the general population. People do not really know this. Treatment is still based on symptomatic control. We have no cure, as you know. Mean age is 60 years, so my age is, maybe I will be diagnosed soon. You never know, I hope not. And early onset is also on the rise. And the prevalence worldwide, when this is based on the PhD thesis from one of my assistant professors, Merel Verhoef. She wrote it 4 years ago, and back then it was 6.1 million people. For sure, it is already more, because we have an aging population, and we have an increase in all kinds of factors that we increasingly know that they are involved in the etiology of Parkinson's disease, like the use of pesticides. And we have a famous professor here in the Netherlands, Bas Bloem. He is world-renowned Parkinson expert, and he is really making a big plea of reducing or abolishing even pesticide usage to prevent Parkinson's disease from rising even further as it already does. So this is just to introduce Parkinson's disease, but now going to the orofacial pain and dysfunction in Parkinson's disease. Back then, my PhD student Merel Verhoef, she did not know, and we did not know, what was actually going on in Parkinson's disease patients as far as these conditions are concerned. So we were setting off to do a scoping review in 2022. So we did the search. We found more than 7,000 papers at the onset, and 50 remained after selection of titles and abstracts. And then we found quite a few things. So if you compare in these papers Parkinson's disease patients, so PD patients with controls, we found in Parkinson's disease patients more orofacial pain, self-reported, more so-called temporomandibular disorder pain, which is pain from the muscles and the joints, the jaw muscles and the jaw joints. We found more limited mouth opening. People who have pain or dysfunction of the masticatory system, as we call it, they usually have difficulties opening the mouth wide, and this was more prevalent in PD than in controls. Reduced bite force, more chewing difficulties, which is an important finding, because chewing is so important for your bodily health, your general health. Sensory disturbances were found more frequently, and also bruxism, the clenching and the grinding of the teeth, we call it bruxism, is also more frequently found in Parkinson's patients. So we already knew a bit more based on this scoping review. So yes, then the conclusion is that we need more awareness of these problems amongst healthcare providers, because they occur so commonly. So what's next? We did a pilot study in using self-report, trying to find out TMD pain, so the muscle and the joint pain, and this bruxism during sleep as well as during wakefulness in Parkinson's disease patients, 368, and a slightly less number of control patients. And we found more pain, more bruxism in Parkinson's as compared to controls. But yes, this is only self-report. So we moved on, creating a protocol. And this protocol was that we're going to assess TMD pain clinically. We have very good techniques to assess that in the dental office with validated instruments. And also bruxism for sleep and awake. We were adding instruments to the diagnostic procedure to be more certain that the diagnoses were actually valid, so that we could really say something about the association. So the protocol was published. We like to be transparent. And then COVID started. So we had this nasty COVID period, and we could not start the protocol. So Merel Verhoef, she finalized her PhD without doing this study. It was the plan to do it, but now we have a new PhD student. She is working on it, and she is already almost 2/3 in the collection of the data. We need almost 300 participants in total, and she has arrived at the 200, so 100 Parkinson's, 100 controls. It's very labor intensive to do all the clinical assessments and all the instrumental assessments, but maybe I hope that we can finalize in a year and we can publish some, let's say, rock solid data on the association between Parkinson's disease on the one hand and orofacial pain and dysfunction on the other. So this is to be continued. But the pilot is promising, and we did not do an interim analysis, but I'm sure that we will find interesting things here. This was an interesting paper that we published in The Lancet in 23, a brief paper though, but still, it was about the importance of a healthy mouth in Parkinson's disease, really underexposed. And you can imagine, you're specialists in this domain, that if people lose their ability in terms of cognition, but maybe also in motoric way, in how well they can handle their own toothbrush and other cleaning means, that a healthy mouth in Parkinson's disease is not something that is always there. It will deteriorate if you do not pay specific attention. So we thought to make a plea that not only dentists, but also medical doctors, we should know more about each other's domains. So we are implementing more knowledge on Parkinson's disease, but also dementia, in our training of the dentists in Amsterdam. And we hope that the medical curricula will include more dentistry in their teaching, so that we know better what we are doing, and that will improve the communication between medical doctors and dentists, and thereby improve the quality of the care that we deliver. So this is all about education, and then in the end we hope that these new insights will improve in the end the enjoyment of life of Parkinson's disease patient quality of life. This is our hope. So we published this in The Lancet. We also published it in the Journal of Dental Research, which is the highest ranking dental journal. So we hope that we have, by these two main journals, that we have reached the population in the maximum possible way, and that people will start thinking, okay, maybe we should do more as dentists on Parkinson's disease. And maybe we should do more as medical doctors on dentistry. Why not? We are working on the same body. So now, next topic, this was Parkinson's disease, very brief, the mild cognitive impairment, MCI, and especially dementia. This is, of course, I have to show now a German doctor after a UK doctor, Alois Alzheimer, and he is the man after whom the most frequently occurring dementia, as we think now, has been named after, also a long time ago. This is basically a group of neurodegenerative conditions characterized by, well, I'm not going to tell you anything new, but it's more to warm up for myself a little bit, memory loss, cognitive and functional decline, impaired communication, behavioral changes. Well, the list is endless. All the characteristics you will be familiar with. Most common is Alzheimer's disease, but we also have the vascular frontotemporal Lewy body and others. And the prevalence, and this is a startling number, the prevalence doubles every 20 years worldwide. So this is something that we have to think about if we plan future care. We have to take this into consideration. So we have finalized 4 PhD theses that you can see at the bottom of this slide so far on this topic. And if you look at the expected number in 2050, 115 million people globally are expected to suffer from one or the other type of dementia. This is really something that we have to take into consideration. But then we know that pain in mild cognitive impairment and dementia is highly prevalent, but then is this studied widely? No, it's not. We do not know a lot about this. To be honest, we know only very little about pain in dementia. And then talking about pain, what about orofacial pain? But first, pain in general. I was part of an international European cost action already 10 years ago, and we set off to develop a tool for the assessment of pain in people with impaired cognition, especially dementia. It's called PICE, Pain Assessment Impaired Cognition, PICE. And we developed a tool, an observational tool, that could be used for the assessment of pain in people with those kinds of conditions. The final tool had 15 items, 5 facial expressions that you could observe, that could be witnessing pain, 5 body movements, and 5 vocalizations. We published this in good journals, BMC Neurology, European Journal of Pain, and I will show you the 15 behavioral signs on the next slide. This is the form that goes with it. So it's observational tool, and you can see that there are 5 vocalizations mentioned here. So people who use pain-related words like ouch or that hurts, things like that, that would point obviously in the direction of pain. Shouting can be behavioral change, but it can also pointing towards pain. Groaning, same thing, mumbling, complaining especially also interesting because it can be complaining as part of the dementia paradigm, but it can also be a manifestation of pain. So be aware that if people have those kinds of vocalizations, also think about pain. Body movements, freezing, guarding, resisting care, rubbing, restlessness, everything again can be part of dementia, but it can also be indicative of pain. And of course, from a dental point of view, the facial expressions are the most interesting. Frowning, narrowing of the eyes, raising the upper lip, opening the mouth and looking tense are all known to be associated with pain. And this is then a little bit of a museum visit. If you have ever been in Amsterdam, and some of you have been, I know, we have the Rijksmuseum, which is, I think, a very nice museum. There is this little wooden head, 3D head of a little child that shows all the expressions of pain. And that is because if you look at the temple here, there's a big bee on the temple of the kid that stings the kid. And so there's an acute pain. And in the acute pain situation, you can see all the things that I just mentioned. There's frowning, there's narrowing of the eyes, you can see it clearly. The upper lip is raised, the mouth is opened, and, well, you can also say this is tense looking. So all the 5 facial expressions that are indicative of pain, they are there in this face. So if you ever go to the Rijksmuseum, check out on this little statue of a child, and you will see all the facial expressions demonstrated there. So all the items, all the 15 items, they were tested for psychometric quality and clinical usefulness, and they were all in order. So that's fine. But then for clinical practice, it's a little bit long. This is more or less a little bit time consuming. So we were setting off to make a briefer version. So yes, we finished this in 25. So that was last year. We reduced from 15 to 6 items. And thereby the observation time could go back from 5 to 2 minutes, which is a 60% reduction. And if it only costs 2 minutes, I know if you work with people in nursing homes, it's still a lot of time. It's significant time, but 2 minutes is always better than 5. So if you have somebody in whom you suspect a pain, this is something that you can easily do. Do not do it with all your patients on a routine basis, but when you observe something, you have suspicions, go for it. So also this one was tested for psychometrics, highly valid, highly reliable, and clinically meaningful. And we now have 2 facial expressions left, 2 body movements left, and 2 vocalizations. So nicely symmetrical, all went down from 5 to 2. And these are the ones that are left, the frowning and the raising of the upper lip, freezing and guarding for the bodily movements, and the vocalizations, the pain-related words and growing, they were considered as indicative of pain. So now we have a brief, valid tool that I can really recommend to you to use in your clinics, in your nursing homes where you work. It's applicable to general pain, but then the big question for me as a dentist is, how does this work in orofacial pain patients? So is there, in another way, is there an instrument available that really focuses on orofacial pain? Because orofacial pain is something that is prevalent. It is in an area that you can easily observe. It's here, it's outside of clothing, it's outside of everything, you can see it. Is there an instrument? So we did 2 reviews in the literature, and basically the conclusion of the 2 literature reviews was the same. There are no tools at all for the specific assessment of orofacial pain back then. We are talking the newest one, 2017, which is 9 years ago. So if there's nothing, and we considered it important that there was a specific instrument, we developed one ourselves. We are dentists, so we work a little bit with developing new things. So we developed the orofacial pain scale for non-verbal individuals, the OPS-NVI, based on the Pike instrument. So if you look at the form on the left-hand side, you see familiar things. You can see the vocalizations again. You can see the body movements again. You can see the facial activities again. But we added a couple of specific, very dental aspects to this form. Namely, restricting jaw movements, which means that if people are in pain, they do not open their mouth as wide as they usually would do. And you can imagine if you hurt your knee, you will not bend your knees completely. You will make restricted knee movements. It's the same with the jaws. If you have pain here, you do not open wide. So this is a very specific one. Another one is refusing prosthetics. If somebody is in pain, and many of your clients, patients will have prosthetics that you can take out of the mouth, they will not allow you to take it out, or if it's out, to put it back in, because that hurts. That's also a specific one for orofacial pain. And the last one, that's a very interesting one. Acute pain is also associated with drooling, so saliva loss. And yes, drooling can have multiple causes. It can be medication, caused by medication, but it can also be caused by acute pain. If people are in acute pain, the drooling increases or starts. So these specific ones were added to the instrument. And yes, we also enabled the observation during 4 different situations. So we observe with this tool, the OPS NVI, our patients during rest, when they are doing basically nothing, during drinking, and then especially hot drinks or cold drinks, they will provoke dental pain. Maybe one of you might have had toothache. If you go then to the dentist will perform hot and cold tests, and you will not like it. The cold test will give you an excruciating pain in the tooth that is inflamed, and also a hot test will do the same thing. So we can do that with drinking. You can mimic this. Chewing, if you have a pain in the muscles or the joints of the masticatory system, if you start chewing, that will provoke the pain. If you use your jaws, it will be painful. And also oral hygiene care. If you brush the teeth, you have to move the mouth, you have to touch the gums, you have to touch many things. If that provokes those kinds of facial expressions, body movements, and vocalizations, it will be indicative of orofacial pain. So this tool was developed, it was tested for psychometrics, it was found to be okay, not as good as the Pike in general, but it was good enough to be used. So we applied it in 2 different settings, in acute hospital wards, and that is something that is, I think, almost unique for the UK. This study was done in London, together with colleagues at one of your dental schools and psychiatric departments. Orofacial pain was found to be present in 11% at rest and about 1/5 of the population during chewing. This is not a very high percentage, but at least it shows you that it is the same percentage what we observed in the general population. So do not assume that your patients in your acute hospital wards will be free of pain. They will have pain as much as it is there in the general population. And if you then want to know which patients of these 100 patients will be at higher risk of having orofacial pain, well, then these are the ones with the low brush frequency, which makes kind of sense because their oral hygiene will be less, difficulty swallowing, when they have poor chewing quality, and using soft food. All those characteristics will increase the odds that they will have orofacial pain. So this is the recommendation for the people taking care of those individuals. Improve the oral care, please, in the acute hospital patients with dementia. It's imperative to reduce the pain and the suffering in this population. So these are the acute hospital wards. But then we have, of course, also the nursing homes. And now it's getting to be even more interesting. We did the full OPS NVI, all the subscales, and we found that almost half of the residents with dementia had orofacial pain based on the OPS NVI, as compared to only about 15% of the residents without dementia. So this is a big difference. So there's a huge amount of suffering, especially in the part of the population within the nursing homes who cannot tell you that they are in pain. So it's an urgent plea to be observant and use the tools that are available nowadays to assess the likelihood that people who behave differently are not just behaving differently because they have dementia, but also behave differently because they might be in pain and might be in orofacial pain. Predictors were basically the same as for the acute hospital: soft diet, dry mouth, being dentate. If you have your own teeth, of course, obviously you will have more orofacial pain, and poor oral hygiene. So here, as in the acute hospital wards, please, people working in nursing homes, take care of the oral health of your residents. It should be part of the routine, actually. And I know I heard from people working in nursing homes that they rather change diapers than that they brush the teeth of one of their residents. Maybe this is an exaggeration, but it illustrates that people are hesitant to brush the teeth of another person. Don't be. It is as important as brushing your own teeth, and it is not. I mean, I work with mouths, of course, every day, but it's doable, even if you find it maybe a little bit, I don't know, sticky or whatever. Put on gloves if you want and do it, because it's so important in the end for quality of life of people living in nursing homes. Don't be hesitant, and ask dentists to be trained. That's always possible. So what about the oral function? This was the pain part, but we also have the function part. Let's say the decrease in chewing, the limited mouth opening. So we did this in outpatient clinics and in large numbers of individuals. It was a huge study. It's not easy to study people with dementia, because you need, as you probably know, a lot of permissions from medical ethics committees. But we found nothing peculiar, actually. It was like, if you compare the number of teeth touching from the upper and lower jaw in people with only mild cognitive impairment, they had at least 5 pairs of teeth from the upper and lower jaw touching, which means that they can still function quite well. But in dementia, there was the median value of only 1, which means in the entire mouth, there was only at one spot that people could touch the upper and the lower jaw via their teeth. So try to chew on one occluding pair. That is difficult. So there's a problem there. It needs to be prevented. Maximum mouth opening was larger in people with MCI as compared to dementia, but believe me, these are normal values. 50 millimeters for the MCI people and 45 millimeters, 46. Even though it's significantly reduced, this is not clinically meaningful. This is big enough to eat and to brush your teeth. So sometimes statistical significance is not telling you anything. It is also about clinically meaningful findings. Tooth wear, which is wearing down of the teeth, which is something that increases with people getting older. You use your teeth, it wears down. Nothing remarkable, and similar for MCI and dementia. So the most important difference was the number of teeth touching when biting down. That was 5 and still acceptable in MCI, and only 1 in dementia as a median value. And that is something that is a bit startling. So what about chewing and dementia? This is important, because chewing is not only breaking down your food. You're probably aware of the importance of moving for your cognition. And the funny thing is, this is already an old review, but it's still one of the best reviews that a former PhD student of mine did. Roxana Weijenberg, she published, it is a top journal, Neuroscience and Biobehavioral Reviews. It was mastication for the mind. How important is mastication for your cognition when you're older? And she found that chewing is positively associated with cognition, especially based on animal studies. So in animal studies, quite convincing. You can, of course, manipulate the food. You can manipulate the number of teeth that these animals have. And you can measure their cognition by all kinds of cognitive tests. Very positively associated. Worse chewing, worse cognition. Very clear. But what about humans? This is, of course, more difficult to test. You cannot take away teeth and then place them back as you could do in animals. You can also not ethically change the diet of a person and then put it back on another diet, a more tough diet, that you cannot do that. So you have to work with other means. So we tested first in healthy, cognitively healthy older people, and we found that people who are full denture bearers, so they have removable prosthetics in the upper and lower jaw, can take it out, and you compare them to people with their own teeth, so fully dentate older individuals, the people with the removable prosthodontics, they had an impaired episodic memory and an impaired executive function. Cross-sectional, but still a nice indication that there might be something that is in line with what I showed on the previous slide in animals. So then we moved on and went to the nursing homes. This was a big study based on more than 300 individuals again, and we set off to test the cognition in those people with dementia, and we also let them chew on 2-color chewing gum. And this is a clever tool, basically. I did not invent it, so I can say it was clever. It is a red and blue chewing gum that is glued together, and you offer it to an individual and you ask them to start chewing on their habitual, so their normal chewing pace for 10 seconds. Then you take it out. Can be a challenge, by the way, with people with dementia, but it is possible. And then the better people have been chewing, the better the colors are mixed. So the upper two here, they are examples of a good chewer. The lower ones here, they have been chewed upon, but only very little. So the mixing ability, the better the mixing ability, the better the chewing efficiency is. And we found that people with chewing difficulty, so people who are more like bad mixers, they had impaired global cognition and impaired verbal fluency. So it's associations, it's not longitudinal. We did not do any interventions to prove this, but still it is in line with the findings from animal work. So I think that based on these kinds of studies, and has been replicated after that also by others, that there is something there. There's more to the mouth and cognition. Also, if you look at periodontitis, you know the inflamed support tissues of the teeth. You have bleeding gums, you have breakdown of the bone. The more severe these periodontitis problems are, and extensive loss of teeth that is consequent of severe periodontitis, this is also strongly associated with cognitive dysfunction. So the more periodontal problems, the more teeth are lost from your mouth, the worse your cognition. This is based on an umbrella review, so it's a systematic review of systematic reviews, the highest possible level of evidence. So this is really strong evidence. You have to take care of the mouth. Again, big message here. If people are getting older, they're getting frail. And I guess that you know the term frailty is popular. Oral frailty might be new for you. So aging, there is an increasing need for oral hygiene support and professional oral care, because oral health reflects oral frailty, and we need definitions, because oral frailty is a new thing. It's the new kid on the block. So I have a new PhD student, Carl Parisius, and he set off to define oral frailty. And based on all kinds of literature assessments, he came to a very simple definition. I love simple definitions because it makes life a lot easier. And he defined the conceptual definition that oral frailty is the age-related functional decline of orofacial structures. So it's age-related, it is decline of function, so chewing is reduced, swallowing is reduced, speaking is reduced, of the structures of the orofacial system, of the mouth and everything around it. That's what it is, no more, no less. And then he came up with an operational definition, because the conceptual definition, that's fine, but now you want to measure it. So he did an international e-Delphi to investigate which components are most characteristic of oral frailty. And he came with 8 components that were grouped in 4 categories. The categories are mastication, swallowing, oral motor skills, and salivation, which is, let's say, dry mouth. And you can see the components beneath it, which is, well, they are very detailed, but if you have difficulty chewing, difficulty swallowing, difficulty with speaking or moving your tongue around, and if you have a dry mouth or too little saliva, these are all parts of the operational definition of oral frailty. And he is now working on an instrument to measure oral frailty. And he just submitted it, I think, today to a journal. So we are there, but not completely finished that I can show you. So the next step is ongoing. But I think in maybe a couple of months, I hope to have better information there. But now, I know that I'm running out of time. I'm sorry, but it's a bit. I'm a little bit long in my words. I realize that. Blame it on my enthusiasm. People reach end of life at a certain point. We all do. And then there was this Lancet Commission, and it was on the value of death. And I know that many people have read this, and it's an important piece of work. It was about that dying and death, it should be recognized as normal and meaningful, no life without death. Well, it's all true. And they said, and rightfully so, that all medical professionals should be competent in palliative care. And then I read this whole document, 80 pages, 80 pages, not a word on dentistry, not a word on oral care, nothing. So then no mention there. So we wrote a brief paper to the Lancet again to express our surprise that by reaching end of life, there are so many debilitating oral conditions like dry mouth, halitosis, and pain, that there really needs to be attention in palliative care also for dentistry. If you have a dry mouth, you cannot talk anymore, and that's important at the end of life. Halitosis, it's a bad breath. People will keep distance, whereas you want to have your loved ones nearby. And if you have pain, that you do not want to have too much pain, preferably no pain at the end of life. So dentistry is really important. So it should be part of palliative care, and then it means that palliative oral care will also improve quality of dying. I don't know if you're familiar with that term, but I think that we always talk about quality of life, very important, but also at the end, dying should also be of good quality. So my final part here is about medicine and dentistry. I started off with a plea that medical doctors and dentists should talk the same language. We also published this in the Lancet. We published it in the Journal of Dental Research, really making a plea that dentists and medical doctors should work side by side, not like this, that the dentist and the medical doctor are worlds apart, but we want to continue like this, that we are really one team, medical doctors and dentists, speaking one another's language, working together as to improve the general health and also the health equity globally. So this is the little movie. You will not hear the music, but you can see the dentist coming in. There's the lady again who was admitted to the nursing home. And it's a bit cheesy maybe, but I like the movie. Yeah. I've witnessed this dentist working, and I'm really impressed by how she is approaching with all the love that she has for this specific population, and people they follow what she does, and it's amazing. I can only be very impressed. I do not do this work myself in nursing homes, so I'm really happy that people are doing this, and especially with colleagues like this, it's fantastic. So in summary, I think the three conditions that I touched upon in my presentation, Parkinson's, MCI, and dementia, I abbreviated as PMD, are common conditions in the aging population, and orofacial pain and dysfunction, like bruxism, they occur more frequently in PMD than in otherwise healthy controls. Self-report in PMD is impaired, as you all know, and we need observational skills to observe if there is a likelihood that pain is present. End-of-life care should include oral care. I really stress on this. And then final point, that's my big plea, dentists and medical doctors, we are one team. So let's work together to the benefit of our patients. So this is the paper that on which I based the main part of my presentation. I added a few new papers, of course, because it's an update of another presentation. I will send this PowerPoint to your group so that you can read it. You can scan the QR code. It's an open access paper, so you can read more, and all the reference in there will be available for you. So that's it. So thank you very much for your attention, and I'm sorry that I was running out of time, but that's my fault.
I think that's not a problem at all, Frank. Thanks for your
Okay.
enthusiasm. And
Thank you.
and thanks for the story. So I think it was a very interesting and very nice overview that you guided us through. So that good work takes time, we would say. So many thanks for that. Perhaps there are a few minutes left also for questions. So if there is someone who has a question, just looking at my chat and my screen as well. I'm not so good at multitasking, so are there any questions? Because otherwise I can start. I think perhaps, oh, there is Pat. I see your hands raised. That always helps.
Thanks, Sandra. Thanks very much, Frank. That was really interesting and really important. We've been doing some work in the UK with some dentists around dental pain and care homes. And as you say, it's not well recognised because people think, oh, they're losing weight, they're not drinking, but they don't think of oral problems.
Yeah.
Pain is not routinely assessed, so that's always a bit of an issue. And a couple of other things as well. You mentioned dentists and doctors working together. That would be so good if we could do that. We don't have shared care records in the UK between dental services and doctors. And as you know, we have a shortage of dentists in the UK. And one of the big issues, I think, is if somebody does have a dental issue in a care home, they're transferred to hospital, which doesn't do a lot for their cognitive impairment. So I don't think it's a question, it's a number of comments of things that we found with our dental studies in the UK that really reflect what you've been saying. So thanks so much for that.
Yeah, you're welcome, Pat, and thanks for adding the information about the UK situation to this story. You know, I work with Liz Sampson also.
Oh,
so
yeah.
that was the person with whom we did the UK acute
Yeah.
hospital ward and nursing home studies, which was fantastic. So I'm a bit aware of how it was at least a couple of years ago, but for sure it might have been decreasing in quality even more, like also at some places in the Netherlands, by the way, from a dental point of view. We have laws now that all nursing homes are obliged to deliver oral care. My wife is doing this work, and she tells me that it is very hard to do. She is responsible for, I think, 5 nursing homes in the Utrecht area, which is a lot. It's not possible for one dentist to do that alone. So by law, it is all the houses are obliged to do this, but in practice, it doesn't work out yet. And we also have a shortage of dentists. And working with old people is not the thing that dental students nowadays want to do. They want to do surgery and orthodontics and, you know, the flashy things.
Yeah.
Which is very sad. Yeah.
It is. We do have one dentist in Essex who's been testing a service that goes out to care homes.
Okay.
So hopefully some results will be coming out soon.
Very
But
good.
thank you. That was really interesting.
You're welcome. And thanks for your comments and the additions. Thank you.
Okay, I hand over to Manuela. Manu?
Yeah, Frank, thank you so much for the presentation. Maybe first information from Austria. In Austria, we had a project, I think 5 to 7 years ago, where they tried to get the dentist into the nursing homes. I think it was a 2-year project, so pretty big and long. And at the end, they said it's not the effect that they wanted. So why should we get money into that, more or less? So yeah, that's great. It's crazy, but yeah. But I have really a question. I'm thinking about when I'm going into the care home and a nurse or a nurse assistant is asking me, okay, if there is a person with dementia or cognitive impairment, you mentioned so many different small aspects like bruxism, salvilla loss, open the mouth, and things like that. Maybe from your experience, can you give, I don't know, 2 aspects that you say, if these 2 occur, go for it and look at it?
Okay. Well, that's a bit of a challenge. You asked me to make a choice. Well, from my point of view, I think that if somebody is refusing something like a toothbrush or food, whereas you know that they should actually be hungry and normally they were allowing you to brush the teeth. So it's a change in behavior that of course requires that there's somebody who knows the client from day to day on a daily basis. If there is a change in accepting something entering the mouth, that would be for me a red flag. And the second one, I think that if people hold their jaw like this, I don't know if you can see my face, but if they hold their jaw, that is the patients are actually tending to cover up the area that is painful, and it also helps to reduce the movements. So suppose that I'm holding my jaw and I want to yawn or I want to say something. I cannot open my mouth that wide. So by automatically, I will restrict the opening of my mouth. So these 2 would be my 2 cents, the core indications that something in terms of orofacial pain could be present.
Thank you very much. And thank you also, because I think 1.5 years ago, we had Wilke Achterberg here from the Pike. there he told us that he will, or you as a group will make the short version of the Pike. I was not aware that it is already published, so thank you for that.
Yeah, you're welcome. Yeah, Wilco is very active in promoting the Pike and everything around it. And I see Hanneke present. Hi, Hanneke. Nice that you're there. So the Leiden group is always very active. That's nice.
And I was also thinking about what you mentioned, Frank, about how is it incorporated in education and regular education? But that also accounts, I think, for nurses in general, with regard to pain, but also with orofacial pain.
Absolutely.
I think there is a lot of there is a lack of good instruction, information, education, knowledge within nurses as well. Not regular being part of their normal educational trajectory, I would say. So there's also some work to do with regard to that.
That is a very interesting point. So why don't the two of us, and maybe some others joining, write for a good nursing journal? Just a brief piece on the importance of oral care in nursing homes. Would be interesting.
Absolutely.
I'm open to do that. It would be. I'm not going to say that I never thought about this, but it's not, let's say, something that I regularly promote. I'm not talking so much about nursing, which is bad. I'm sorry for that, but that's how it is.
No.
So I'm talking about medical
we
doctors
are
and
with many,
dentists.
so we will advocate for them as
Good.
well.
So whenever you want to do
Joint
that,
effort.
let me know, and I'm willing to do that.
That's a good idea, I think. Yeah. It's also with the shortages you were mentioning, I think there is there could be a very important role in that as well, to say, well, you have to have pick up signals. What should you do? Be alert, be aware of it. It's the first thing.
It's all about awareness. You have to think about it, otherwise you don't see it.
Exactly. Other questions for Frank? Well, if there are not, I once more would like to thank you for sharing this with us. It was extremely interesting, and I think it's an extremely important topic that we will pick up on. And well, I will connect Frank as the invitation.
And I'd like to say again, I'm really honored that you invited me. It was a big pleasure. And let's and I will consider joining your network. It's really, I'm impressed by all the things that you organize. So so we will see each other. Yeah,
thanks a lot.
Great to recruit you. And from our side, another great example that these webinars, where sometimes we have fewer people, actually are very rich in terms of the exchange. And if you come up with writing a commentary or an article together after this, we're going to be very delighted. This is a really nice outcome. And we will be sharing the slides and the recording, so we can also keep spreading the word even after the event. So thank you so much. Another fantastic webinar from the group, and welcome, Frank. We'll send you the link. And yes, we will be sharing the recording in a couple of weeks or so.
Perfect.
Thank you. Have a good day and good luck with the heat.
Thank you.
Thanks a lot.
Bye.